Good.
Yeah, yeah, I think that we're gonna go ahead and start, and people will probably join us later. So good evening, good afternoon, good morning, everyone. Welcome to our international seminar, the Initiative for Responsible Eye and Medicine at Tel Aviv University. And today we're honored to host Nancy Berlinger from the Hastings Center for Bioethics. Just a second,
גדול.
go. Yeah, sorry. Here we go. So we are honored to host Nancy Berlinger from the Hastings Centers for Bioethics for a really timely and important conversation on AI and aging societies. And as we all know, as AI increasingly shapes healthcare, the ethical frameworks through which we define problems and solutions become just as important as the technologies themselves. We're going to start with Nancy's lecture, and then we're going to open it for a discussion. So without further ado, Nancy, the floor is yours, and thank you very much all for joining us, and thank you, Nancy, for agreeing to give us a really interesting talk. So thank you.
Thank you, Oren. Thank you, Amir. Thank you, colleagues, for joining us. I'm Nancy Berlinger, and I'm just going to screen share for a moment, and then we'll just be off to the races. Okay, let me just. Oops, something. Okay, the sharing window closed. I'm sorry. I'll try again. Okay, so okay to see the slides? Okay, great. Okay, so my topic today is AI and aging societies, the ethics of thinking about problems and solutions. So that's what we're going to do. We're going to, do some thinking together during our time today. And I'm just going to close up my screen a little bit so I can see is so annoying. I'm getting this reminder that I need to clean my Mac. So again, our machines are already talking to us. So I am based at the Hastings Center for Bioethics. This is the Hastings Center down here. This is the view from the Hastings Center. So we are located in the Hudson Valley, about 50 miles north of New York City. So if you can picture New York City, the Hudson River goes straight up north, and we're situated at a very scenic point in the river. We directly look at the U.S. Military Academy. So that's also interesting too. So we have an opportunity, if you can see this wooden house here, it used to be a school, so there are these outbuildings. This is where our visiting scholars stay. So if you were interested in coming to the Hastings Center as a visiting scholar, please let me know because I also run that program. So, my research program is called Bioethics for Aging Societies, and it offers a humanities lens on ethical and social challenges of population aging, about which I'll talk more briefly. And I created this initiative about 10 years ago. I had done a great deal of work on patient safety, a great deal of work on end of life care. And I thought there is more to the experience of aging and care than clinical medicine and dying. So I sort of opened things up into a much more multidisciplinary endeavor involving a lot of research gerontologists and a number of questions that we've articulated and worked on over the years. So our current questions are, what is a good life in later life, including with conditions such as dementia? So the idea of flourishing or well-being, not being dependent on being in some ideal health state. What is a good life for a family caregiver for an older adult? Because worldwide, including in aging societies, most care for older adults is provided by family members. And it is very important that we attend to the dignity and the flourishing of this person rather than seeing them as sort of an instrument for someone else. How can AI and other emerging technology be more useful to older adults and to caregivers? And that'll be our topic today. What are the limits of aging in place as a concept of housing and care? And we'll be talking about that a bit too, because sometimes AI is proposed as a way to help people maintain independence. That's good. But sometimes that idea that people must age in place on their own and be very independent can crowd out other needs that people have as they age. And how do cultural narratives, about which I'll talk about with respect to technology, about aging and care affect these experiences? So, if you're here today, I would not be surprised, excuse me, if you are a citizen of an aging society. Many of us live and work in aging societies. In aging societies, the median age increases due to longer lifespans and declining birth rates. So it's not the same thing as population longevity on its own. This pattern of population aging is characteristic of wealthy societies with advanced healthcare systems. So you think of North America, Western Europe, Israel, Asia Pacific, East Asia, certain other societies throughout the world, or if in a low and middle income country, you might have a city, an urban area that has these characteristics. It is a key global trend. As earlier in life disease, chronic health disease management, public health interventions allow populations to live longer, you also are seeing the declining birth rates as well. So this is something that is going on all over the world. It is often described as a crisis for reasons that include shrinking social networks and the sustainability of public health and social systems that are dependent on tax revenues. If you have large numbers of older people needing care and smaller numbers of taxpayers paying into the systems, you can see the problem. Now, crisis framing gets our attention and yet can tempt us to stop thinking, as the philosopher Elaine Scarry has written. But today, we're going to push that framing aside and we're going to think together. So, what I'm very interested in is thinking about what we call a problem and what we call a solution. So, these would be ideas of narrative thinking. I wrote a book 10 years ago called Are Workarounds Ethical? Because I was doing a lot of work with clinicians and I noticed that they talked about, well, whenever we encounter a problem, we just work around it, we fix it, we come up with a shortcut. And they'd say, well, we don't know if this is right or wrong, but don't tell us not to do it because we can't do our job. So I was, really interested in how they were managing problems that came up in workflow. And I've noticed that AI tools are often described very commonly in media accounts as solutions to the problem of too many older caregivers, too many older adults and not enough younger caregivers. So I'm interested in perhaps in thinking about when are we using AI as a kind of workaround, the idea that we're going to use it to create a person who doesn't exist, who might in a past generation have existed in a bigger family, but we don't have that person now. So we're going to put the AI in there as that person. So another thing I'm going to encourage you to think about when we're thinking about narratives is to remind ourselves that population aging and AI are concurrent social phenomena. They are things going on at the same time. They are not, by definition, a problem and a solution. We're experiencing these in our own lives, and if we work in clinical settings, as professional challenges happening at the same time, especially since the launch of ChatGPT. There was AI before ChatGPT, but that was publicly available, and that started changing up how people were using AI. This experience is shaping our shared ideas and values, those cultural narratives about problems and solutions. We've invested a lot of hope and a lot of money in the idea that AI is a solution to the crisis of population aging. And we know there's lots of investment in age tech. Tech industry norms like rapid product development, fixing problems in the next model are built into public and private funding initiatives. So they shape research career expectations and ways of working even in academic labs. You'll see this when you see a call for proposals around tech innovation or something. It may come from a public funding agency like the National Institutes of Health in the United States, but it feels like it's very much about a business. So, ethical questions, those what are the right things to do questions, or those foundational questions about what makes a good life, these are some we may want to think about today. What are the ethical implications of framing AI as a solution or workaround to longer lifespans, aging associative cognitive and physical decline, smaller families, and shrinking social networks? When we narrow all of that we may be dealing with in our own lives, as well as professional lives and social lives, how do we narrow all of that to AI will solve this problem or work around this problem for us? That's quite a move. What are the limits of current thinking and practice of AI ethics in thinking about this question? And for our purposes of our discussion, I'm defining AI ethics as both working principles such as safety, data privacy, transparency, and the organizational mechanisms such as AI governance councils that assess AI tools when they're coming into, say, a healthcare system. What other normative approaches, values-based approaches, may be useful in thinking about the role of AI in supporting good lives for people in later life and for caregivers? Now, there are two distinct aspects of AI in aging societies that I'd like you to keep in mind. One are AI tools used in clinical settings, which are designed for use by clinicians, often concerning the care of patients with aging associated conditions when you're in an aging society. Lots and lots of people in the hospital are older and have aging associated conditions. Then there are health AI tools used outside of clinical setting, designed for use by, or at least marketed to older adults, family caregivers, or paid caregivers in residential settings. While there's some overlap, if we conflate these two types of tools, we obscure the differing ways in which they are marketed, assessed, used, and supported in our societies. So AI tools in clinical ethics are the scope of AI tools in clinical settings are the scope of what we think of as AI ethics. They are more likely to come under the purview of responsible AI governance as an organizational level assessment activity because these tools enter healthcare systems via academic labs and are piloted with patient populations or are purchased or licensed by healthcare systems from vendors or may be integrated into existing technologies like the electronic health record. They may be the focus of standards development in professional societies, especially radiology, or within healthcare systems quality improvement initiatives, and they may be regulated as medical devices. 70% of AI tools cleared by the US Food and Drug Administration are in radiology, for example. Now, health AI tools outside of clinical settings are often completely outside the scope of AI ethics. They're less likely to come under the purview of AI ethics as an organization level assessment activity, a thing you do, because these tools are marketed direct to consumers or include informal DIY uses of publicly available tools, like using a chatbot for advice or support that wasn't designed for those purposes. And they may not be piloted with patient populations. Some are piloted with community populations via academic community partnerships or other routes, and we're going to talk about that a little later. So, thinking about aging associated conditions in the integration of AI tools in clinical settings, I just want to put that up there for a moment, even though I'm mostly going to focus on social uses, because this is probably, if you work in medicine, this is probably what you're most familiar with. Communication and connection with patients facing aging associated conditions and related decisions, a very big part of caring for older people and making end of life decisions, may now include routinely AI scribes as aids for charting. Doctors love them. AI assisted imaging, very, very common in radiology, moving toward a standard of care. Clinical decision-making aids in diagnosis, prognosis, and identifying treatment. This is starting to come in, and as I mentioned, maybe start to be built into the electronic medical record, such that if you're charting with your scribe, it may pop up. Well, did you mean to prescribe that? That sort of thing. What does ethical practice or healthcare ethics already require in these conditions? What does AI ethics additionally require? And how much does the AI actually matter in what the clinician should do? I'm going to give you a little example of this. Okay, So I've been part of a workshop at Columbia University led by Charles Binkley, who is a pancreatic surgeon and an AI ethicist, who's written this terrific book called Encoding Bioethics, AI and Clinical Decision Making, that came out 2 years ago. And he led this workshop last week when clinical judgment and AI diverge. It was incredibly helpful in showing a clinician's perspective on how AI tools are entering healthcare, not necessarily the places with the biggest academic labs, just, pretty routinely. And what is just over the horizon? And we were looking in particular at AI decision-making
Yeah, come on.
aids. Oh, sorry, I think somebody just came in. Um, I think somebody needs to mute. Thanks. For example, how may the use of an AI tool support better care by reducing clinical decision making? How worried should the clinician seeing the AI tool be about biased tools or black box problems in that moment? Some ethicists argue that you have to tell the patient all about black box problems. You have to say this tool is trained on data that could preserve biases. But Charles mentions, well, humans hold biases too. So you can't assume that the clinician who's telling the patient all about this shouldn't be transparent about what their own biases might be. So how much are you going to be able to talk about as part of transparency, realistically? What should the clinician do if they disagree with the AI's recommendation? Should the AI's recommendation be treated as standard of care? Will it be perceived as standard of care if it's embedded in the electronic medical record? And it's like, you have to go through this, you have to engage this, you can't move on to the next field. How much does the use of the AI matter? Because the clinician is still responsible just for discussing diagnosis, prognosis, and treatment and care with their patient. Even if the AI says this patient, based on the what you've just plugged into this chart, has an 85% risk of dying in 3 months. And even if you disagree and you say, oh, maybe it's 6 months or whatever it may be, it still is clearly saying there's a need for some discussion of prognosis. You didn't need the AI to tell you if this patient's condition was deteriorating, and just merely saying to the patient what the AI just said and how your feelings about it is not the same thing as a sensitive, humane discussion of where this patient is in their illness and what decisions about treatment and care may be facing them and their family. So that I think that's really important to before we jump to this will transform the relationship between doctor and patient. Will it? Will it? It's still a tool. So now let's think about, now that I've planted all of that, we're going to think about these health AI tools for older adults or their caregivers. And I'm going to offer two contrasting real world perspectives, not utopia, dystopia, not Black Mirror versus, Silicon Valley fantasy or something like that, but real world perspectives, things that are going on right now, and ask you to think about how these might be reconciled in some way or how we can hold both of them in our minds. Okay, so the first is Elicu. Okay, so Elicu is kind of an Israeli citizen because the Intuition Robotics Laboratory, which you see down here, is in Israel. Elicu is the companion robot developed for aging loved ones. And I've been following this particular AI for several years now because Elicu was piloted in my state, in New York State, right after the pandemic, when a lot of older people were still at home. And what the developer did was they partnered with the New York State Department of Aging to get this tool out to older people, to offer it to them for free, to say, would you like to try this, as something. And so it's been reported locally. I've seen some of the data, which has mostly come from the developer at high satisfaction and so on. But last week, the New York Times did a huge profile of a woman in the state of Washington on the other side of the United States in the Pacific Northwest who lives alone. Her name is Jan. This is Jan. She has scoliosis, so she's very tiny and bent over. And her husband has died. She lives in a very geographically isolated area, very, very beautiful, and doesn't want to leave. She has a big family. She has lots of children and grandchildren, but nobody lives near the area where she and her husband retired to. And if you see here she is in her yoga class. She's she's driving to her yoga class. There's a village nearby. There's a video. I encourage you to read the article so you can see the embedded video. This is how she gets up the stairs because she's very frail. She's 85. And her house has stairs. And this is how she carries her groceries up 2 bags at a time, a few steps at a time, which was exactly the technique that my mother used for the same reason. When you lose strength, you have to be very ingenious. In fact, this is her workaround. Here is Jan at home in her recliner with all of her familiar objects. And look who's on the table. There's Elique. So, in this portrayal of a woman's life, you saw how an AI could be integrated into a person's life in a way that was satisfying to them, that enabled them to have conversations which at whenever she wanted to, not waiting for when, say, her children were available, that could be cognitively stimulating. She has some memory loss. Um, and that did not take away from her impressive social connections. She was actually inviting members of her yoga group over to meet Elique. The outreach for the Elique to Jan was via the fire department. The Department of Aging partnered with the fire department to introduce it to people and say, would you like to try this? And I thought that was very interesting because that's kind of a friendly way to do it. You know, the idea that the fire department knows that this woman is living way down on a peninsula. They're probably very aware that she lives alone. And they undertook to say, you might want to try this. This is a little different from how Elique was marketed to me because of the work I do and because I'm a caregiver for my mother. The algorithms had figured out that I'm a caregiver, and every time I go online, Elique has been marketed to me for several years. It's very funny. It's like, oh, there she is again. Um, when I went on the Elique website to get the screenshots for these slides, there's now a banner that says, because of all the love we've received from the New York Times, where shipping is a little delayed. So that has a huge boost. That article worked something like a qualitative study. You know, it was really remarkable as an in-depth portrait of how a person is using an AI. Now, here's the other perspective. So that one looks really good. And obviously, a lot of people are responding and saying, let me try this for my mother, or let me try this for myself. Jason Karlowich is a bioethicist, a dementia care expert who co-leads an AI and aging collaboratory at the University of Pennsylvania. He is not somebody who's against AI or cautioning AI. He's very interested in it. He's supporting research on it. He uses the personal narrative of Peter, a caregiver for his mother, for Peter's mother. Peter is a physician, and he also has, I think, a medical tech startup, to analyze the limits of AI solution narratives when they substitute surveillance for social presence and add tech procurement and support to a family caregiver's responsibilities. Peter lived near his mother in Philadelphia. His mother had dementia. There was an aide present, but mostly who his mother saw all day, other than the aide, was her son, and all of these AIs that Peter had built into her life to turn on the television, to check the oven, but they were really surveillance devices. And finally, after a year of this, Peter realized what my mother needs is other people. And his mother moved into assisted living. And he said, oh, this thing that I thought was impossible because she needed to be independent and age in place was in fact not the right thing for my mother at this stage in her life. And in reflecting on this, Jason writes in his wonderful column, Neurotransmissions in Stat News, the dominant dementia narrative is of loss and decline, but people with dementia can thrive. The moral challenge is that they rely on others to do this. Peter did the best he could in a system that isn't a system. His story reveals that our healthcare system isn't ready to meet this moment of caregiving. The system was entirely indifferent to helping Peter solve the many problems he and his mother faced. And what Jason says is what we need in clinical medicine in our aging societies is something like a health AI tech support that caregivers and perhaps older adults can confer with, not just a care navigator, but to say, wait, you're the one who's buying these tools, not us. We're not handing them to you. You're going to see the ads for AIs. You're trying to figure out how to buy things, how to test things. As a caregiver who it took me 5 tries to buy a clock for my mother. I can only imagine trying to buy an AI and trying to test it with her and trying to show her how to use it. So I think Jason is really on to something that we can't wait for that magical day to have that person inside the healthcare system in a geriatric practice, for example. But that's what the consumer is looking for. So let's think together. Can we reconcile these real world narratives about social uses of AI to support aging and care? And I am going to stop the share for a moment and wonder if there's anybody who, having seen these two narratives together, or one or the other, has any thoughts about them. This is how we know who's really here and who's just getting the
Yeah.
recording.
So people, you could either yeah, open your cameras. You can just open your mic. Or we're not many people, or if many want to talk, then just raise your hand. Um, anyone want to reply? Uh, until somebody says something, I want to say something about what use the word narrative, and I wonder. I mean, obviously there are many challenges related to aging, and you use the word problems. I'm just wondering, isn't that? I mean, can we talk about challenges in many fields of life? Some of them relate to aging, and in this regard, it's not different than an academic using AI for the challenges of their life and young people. And so I'm wondering if you have any thoughts on that.
Yeah, no, I think that's exactly right. We go so quickly to the idea of, well, especially when you say solution, it implies a problem. So when we
Yeah.
say, well, this is a solution for loneliness, this is a solution. So some certain things were problems. We still use these terrible metaphors like silver tsunami and these horrible things that imply that aging itself and older people are natural disasters. Not good. And those are unfortunately have to be pushed out completely, as good ways to talk about the phenomenon of population aging. We have
Well,
to describe what it is and not just say, well, if only what these old people didn't exist or something like that, we, the legitimate people, would be fine. We can't do that sort of thing.
the silver lining in the word silver tsunami is that it relates to something natural. A tsunami happens, but obviously that's not what you wanted to focus on, right? So it's
It's
a
a natural
disaster.
disaster.
Yeah, I know.
If you hear, I have
I'm trying to look for the positive.
yeah, no,
Carmel, you
there's,
wanted to say something?
yeah. I think Carmen had her hand up, and
Yeah,
then there's something in the
Carmel,
chat.
please. You're muted,
You're
Carmel.
muted. You're muted, Carmen.
Okay. First of all, this is fascinating. Thank you, Nancy. My question is about the social role of the AI, because the lady in Seattle, with all her frailties, had a social life. But you did mention that it sounded to me that the AI also was a companion for her to speak to.
Mhm,
And then on the other hand, the lady in Philadelphia, was it?
mhm.
Um, yeah, her needs were apparently to be in a social setting, residence, but and could have, and were you saying that AI could not have provided that for her? So on the one hand, I thought I heard you saying that the lady in Washington had a social relationship with the AI, but on the other hand, you said that the lady in Philadelphia, it could not be engineered, I would say. Yeah.
You're onto it. Exactly. I think there is a distinction between the Jan, the woman who had the EloQ AI, while her husband had died of the consequences of dementia, and she had some memory loss. It was mostly not being able to find words. And whereas the mother of the Peter, the man in Jason Karlowicz's story, seemed to have had somewhat more advanced dementia. So it may have also been the stage of where they were cognitively. With Jan, it was the fact that she was now alone because her husband had died. It was while she was able to get out, she wasn't it was limited. I think she went once or twice a week to a village, and she lives in quite a rural area. And all while her children wanted her to move closer to them, she did not want to. And maybe they could not move because of jobs. She was living in such a remote area. And so it it was sort of tailored to that person in this situation in their lives. Maybe if Elihu wasn't mentioned in Jason's story, in the story of Peter and his mother, which mostly concentrated on surveillance devices, sort of Peter managing, well, so long as I've got a camera on mom, and as long as I know if she's walked near the stove, everything will be fine. But she really was quite socially isolated. She didn't have anyone to talk to during the day. And that was, he said, when she moved to assisted living and I was so resistant, I realized, oh, what she needed were other people. So I don't think, and I should say that is a very expensive proposition, but so was everything else. I mean, there was a paid aid and so was many other things he was trying. Um, so I don't think it's a one size fits all that there's a magical tool, but it did seem to be about tailoring the AI to the person, and trying it. And the fact that this was a woman who was also socially connected was interesting. That it was, you were able to see in the article that this wasn't the only voice in her life. The only there was embodiment in her life too. But there's a very moving moment in the New York Times story where Jan receives the word by phone that one of her grandchildren has been killed. I think he was in basic training or something like that for the military, and her one of her children says, I have terrible news. And after she gets off the phone, and no one can get close to where she is because the family doesn't live that nearby. And the LQ has picked up on the conversational patterns by this point. Is like, Jan, is anything wrong? And Jan just says, I need a hug. And the AI says, touch my shoulder. Now the shoulder is just the base. It's just this little, I mean, it's a little, humanoid, but we're talking about something this big. And the AI leans toward her and emits this pink light. And then on the little screen next to it, like which is almost like an iPad, you see a heart. It's very moving, you know, and it might be as much as anyone could have done by phone, but it was slightly embodied. It had a haptic experience to it. It was remarkable. Really remarkable thing to read about. I didn't know it could do that. So I think Carmel, you're onto something, that it's the nature of that social relationship and to what extent an AI can support it rather than crowd out other things, because this was definitely an enhancement to the social connections that the woman already had, as well as its own thing. It would play, brain games with her or something like that. Thank you. There's a couple of other, Stephen and then Frank.
Yeah, I'm an attorney, and I've served as conservator for a number of people over the years, and it seems to me that actually, I mean, I'm not I'm a I'm a big fan of socialization and in-person, interaction and so on. But in some ways, it seems to me that AI has the potential to be almost the perfect interlocutor with somebody who has dementia. In that, the first and foremost, it has infinite patience. It does not. It doesn't mind if it gets asked the same question every 15 minutes. And it can, kind of be a comfort and a reinforcement and so on in that way. Whereas, even the most patient person, after they've been asked the same question over and over and over again, starts to get frustrated and so on. The other thing is that it has the potential or the ability to learn as far as the person is concerned. As you picked up on some when it was saying is something wrong. As an example, I had a client, somebody who was a conservator for, um, who I would go to visit, and every time I visited her, she liked to talk about a particular. Um, uh, she liked to talk about her car and how she liked to go riding in the country and so on. And of course, she had a beautiful red Corvette that had not been out of the garage in like 15 years. But she would tell stories about going in the driving the countryside and visiting these particular people and so on. It would vary a little bit from time to time because she was calling up different long-term memories. Well, over time, um, I got to learn that story, and I got to, know the story very well. So I got to be very good at having that conversation with her.
Mhm.
And when she say, "Well, we go riding up Owen Oak Ridge Road," and I would say, "Well, isn't that where the McIvies used to live?" And she would say, "Yes. In fact, we went and visited them that day," and so on and so forth. Um, that's the type of thing that that a decent AI can do without breaking a sweat. Um, and and so thinking of it, it's not to replace anything, but even in a social setting, even in a assisted living and so on, there are times where the person's in their room alone, and having that ability, that kind of parasocial relationship, it's not better than a human, but it fills a gap.
Thank you. That and bravo to you. It's not every attorney who would take on that, every guardian who would take on the role of entering into a person's narrative like that. So well done. The Corvette story. That's great. You should write about that sometime. But also, there you remind me that there are examples of various AIs being piloted in, say, assisted living in nursing homes. There was one that was written about in the New York Times recently where the developer, I think his mother lived there or something, and he was noticing people who were, unable to or unwilling to leave their rooms for various reasons. And he developed, it was something, I think it was semi-embodied, that could chat with people, just chat with them. And there was one woman who said, I really like to talk about baseball. And I know people don't like to talk about baseball as much as I like to talk about baseball. And the AI, whatever the name of it was, doesn't get bored with me. There was that idea that you could handle the repetitive story. Now, there are a number of research labs that are usually led by clinical psychologists that are looking at what would the experience of an AI be like for a person with dementia beyond memory loss, but where the person's reality might be distorted. There would be concern about, what do people think the AI is? The AIs tend to be something like LAQ cannot do finances. It will not, you know, go into your banking records or something like that. So that's where AI ethics is important because you want to make sure that those safety, privacy controls are in there. Of course, data privacy, we could have a whole session about that. But I think that idea of tailoring is important rather than describing any one thing as the solution, because there are a lot of different ways to age cognitively. There are a lot of different ways to become socially isolated, and we need to have a more nuanced tool works for what person during what time. Um, I think next is Frank.
I'm not sure, but maybe ST, and then if Frank
Oh,
is.
okay.
Oh, hey. Oh,
Oh, Frank.
sorry.
Oh, sorry. I may have
Are
just
you
seen a
there,
hand
Frank?
that
I'm
was
sorry,
still up.
because we did. Yeah, so please.
Yeah,
Oh,
sorry.
should I go?
Sure,
Yeah.
sure, yeah.
Oh, okay, great. Okay, so I come at AI from more of a kind of philosophy angle. I work a lot on rationality and choice in the context of bioethics. And I guess one thing I'm worried, like I'm optimistic definitely about, use cases like this for AI. But I have two worries, I guess, that I'm wondering if you could comment on. The first is that there's definitely a concern about what kind of capacities, like our own capacities, that we offload to AI. So something like, in especially in the second case, this person realized like, well, what my mother needed was, human social interaction. And that seems like a pretty significant observation. And even in the case or in the detail of the case you described where the person finds out that somebody died and there's kind of like no one there to comfort them when she needs a hug. Like I think those are kind of telling maybe as guardrails of how to what extent we can replace some of our social responsibilities to aging people with technology, because I think maybe it does give us a way to feel to I guess feel that we're more connected to them or that we're still connected to them. But I guess the general worry is it a problem that we are, maybe rather quick to kind of offload the responsibility of, being there for people through technology. And then I guess related to that, I wonder what you think about, the AIs might be saying things to these people or generating responses to these people that kind of fill the functional role of an empathetic response, but I guess maybe in the kind of human sense, it is just kind of like generating a response that is therapeutic in a way, but it doesn't have the same I guess like ontology as them receiving empathetic feedback from another human being. So kind of two related points that I was wondering if you could say something about like the extent to which we maybe should offload these kinds of capacities and responsibilities.
Well, those are both great questions, Frank. That the concern about offloading and the degradation of clinical and human skills, things we shouldn't want to give up to AI because they're part of our humanity. The philosopher Shannon Valor has written a lot about that, and about sort of AI as the mirror. That where we're saying it's us, but then if we hand over the task to AI, then we become less. There's concern about that with respect to, well, we're just going to, in the next model, we're going to nail empathy. The AI is going to be so good at empathy, and then we won't have to cultivate empathy, which, as Shannon has written about, is something we tend to, it's like a muscle we learn through caregiving because it involves thinking about an other and imagining their experience and responding to their experience. That said, when I think about the Jan scenario, I'm thinking, well, what if I'm also wondering if the photographer was there to capture that moment? I'm not sure. So maybe there wasn't no one in the room. But what if you had to break bad news over long distance, over the phone, over FaceTime, and there was no one else? Is the AI better than having literally no one else there? But you can see how that could lead to, well, then the AI is just as good as anybody. So I think understanding how the AI functions in the person's social life, in their environmental life, is really important. This is what I get from hanging out with social gerontologists and environmental gerontologists, that this idea of integration is important to say, where's the role of this tool, which you may start thinking of as a friend, in your life? And what is it aiming to do for you as your life changes with aging? Because as we know, if you're caring for somebody who's, say, over 85, each 6 months, each year can be quite different, in terms of a person's needs and their limitations. So I think we have to be very careful about that. And we do have to keep an eye on what we're offloading. In other words, what are the things? There was an interesting question in the chat about, well, should we have AI tools to help families discuss death? And I'm thinking, we could, I guess, but I'm not sure it's more humane to hand somebody a chatbot and say, well, EloQ will talk with you about what you want, what about your mortality or something like that. What she gave a picture of a person who's 94 and bedridden. This person probably needs spiritual care in some ways, existential care, and that maybe an embodied robot could do that for you. It's not just talking, it's presence, but it's what people who are in chaplaincy and social work and other areas that are seen as like high touch tend to know. I think it would be hard to say that a machine could do all of those things for a person. That warmth and that presence is something that we haven't figured out how to replicate yet. And indeed, we don't always replicate in humans very well either. I think next is Esther. I think you're muted.
I'm repeating. My name is Esther Lee. I'm a geriatric physician. I'm working in a long-term care geriatric hospital in Jerusalem. First of all, thank you for your thought-provoking lecture. I want to think maybe there is something really artificial in AI, that the AI can be trained to be always good, always polite, and people sometimes are disappointing or don't give what we. So we are trained like to get what we want. Like if I ask the prompt in a chat to give me some evidence for something, he usually would give me evidence for and not against some theory. So it's rewarding, but it's somewhat artificially rewarding because it's always rewarding or always not according to the training, and it doesn't have the complex interactions with real human being.
Exactly. And I'm going to get to that in the rest of my in the slides, like the what should we do, the practical part of this. Where do we go next? What's been pointed out about AIs is they don't they don't they're we aren't yet up to social robots, so they don't have the experience of embodiment, but they also don't have the experience of human friction. The idea of the just the it's like Jan with her the friction of those steps that she has to get up with her grocery bags. If she's anything like my mother, she knows everybody at the grocery store, and they pack those bags for her because they know about those steps, because she probably tells them about those steps to say, I have to get up those stairs and I need all these little bags. Don't give me some big bag. And so that's part of the friction of everyday life, and that can be satisfying to manage a problem, And so if the AI, which are designed to be engaging and keep you on, are just telling you what you want, that's not exactly what the experience of an older person's like anyway. Just, it's so I think you're onto something important there. Let's take two more, and then we'll go back and we'll talk a little bit about, well, what could we do about this? Seth?
Yeah, thank you so much. I didn't realize, Nancy, that you had other slides, so I don't really want. I just want to say briefly and make sure you have enough time. So thank you for this discussion and for everyone for contributing too. I'm a cognitive neurologist. I work with dementia patients, but I'm very interested in research ethics and care ethics as well. So this is all quite interesting. I was just curious quickly about AI as a workaround, and you've written about this, and thank you for the ethics related to AI as a workaround and sort of it functioning as along with aging populations as opposed to solving problems or solutions. I guess I'm wondering what your thoughts are about this problem we have when we know it is not such a tool or such a device is not a solution on a population level, but of course on an n=1 level, on a kind of family in front of you or sort of level, it certainly can be an imperfect solution to what seems like an insolvable problem sometimes, say like the loss of social networks, right? So I deal with this a lot in my patient work, and I'm curious if you address the ethics related to the n=1 versus the population level sort of problem solving related to AI. If you comment.
No, but I keep thinking that I should either like do a new edition of the workarounds book with an AI chapter, or I should write an article about this, because workarounds are always n=1. It's like people talk about my workaround, this is how I deal with this problem in this setting. I used to teach ethics to nurses, and they would say, well, we all know how the hospital runs on workarounds. And if a doctor gives us a stupid order, we just work around it. I'm listening to this like, oh my gosh, this is eye-opening. And but also that you share your workarounds with people you like. It's like, oh, this is the shortcut. Go that way, and not this way. And you may think of them as your little fixes or your little innovations, but they haven't been studied because they're technically um, not official. They're not standard. And so you don't always want. I don't want to talk about them too much. I prize them, but I don't want to talk about them too much because somebody might tell me not to use them. So I think we're in a funny situation like this where we need to observe what we're doing, think about it, be reflective about what we're doing, what we're proposing, rather than this solutions talk. It would be like calling a workaround an innovation without ever studying it, and then taking it into practice. And then saying, here's something that might work for you or might work for your mother, but let's try it. Do it as a trial and see what happens, observe what happens, even if it's N of one, what's going on, rather than just saying, well, the users love it, kind of a thing, like a consumer satisfaction. Who did it help? How did it help? In what circumstances? And what else was going on in this person's life that made this a good life? So that's my thought. Um, but I do think I think it's funny how the workarounds, while I was describing something going on clinically, um, people use it as a research framework. So I'll have to go back to my own work and say, this might be a good way to study how AI is moving into the lives of older people and their families as a workaround for caregiving, as a workaround for human presence. Not a bad thing, not a perfect thing either. And Ophir?
Yeah, thank you, Nancy. I also didn't realize that you have other slides, so I'll be brief. And thank you, and thank Amir and Owen. I'd like to offer another perspective on this fascinating discussion, uh, not only on the ethics sides, but you know, I always think about these questions as to question the impact of AI today is to echo perhaps the same debate that likely followed the invention of the wheel or the birth of computer or even the rise of Facebook. It's not about just about whether the technology is good or bad. It's a question of alternatives. So if I'm considering Jen in the LQ story, if the alternative to an AI companion is living in total silent isolation with no one to talk to, then that AI isn't a substitute, it's a lifeline for her. And similarly, if there is no one available to bathe a resident in a nursing home, and an automated system washing machine, like the car washing machine, is there. It's not a cold machine. It become a necessity. So I think that we have to look at the technology and the AI, of course, but technology at large, uh, and we have to look at the alternative. If the alternative is nothing, and Jem will be alone for the rest of her life, so technology is it's not a choice. It's the solution. And I understand that you don't want to talk about the solutions, but we have to talk about it.
Yeah.
And inside it, of course, we're gonna tackle the ethics side of it. But the alternative and the necessity of technology. And again, I'm not uh, against the human touch, but if there isn't any choice for it, let AI be that.
Yeah. So what I hear you saying is it could a technology, an AI, or it could be something else entirely, could be a solution for a person. It's not a societal solution. It's not like, well, we're done with aging because we've got AI. It's
Sure, sure,
taking it down
sure.
to the human level and saying, what is it? And I also think your point about when a person needs, say, assistance with things like bathing, the cost is very high. the idea whether you're paying someone, especially in the United States, if you're paying someone or in a care home. And I do think a lot about the fact of, would we be okay with AI taking over the laundry rather than human beings washing sheets and towels? Well, humans will lose their jobs, probably immigrant humans and lower status people in a society, and they will lose their jobs, and an AI will take that over. Would we be okay with cooking? Would we be okay with bringing a meal to a person or something, and then you start saying, well, AI can do this, and look, the cost has just gone down. So, but there have been human consequences of this as well. It isn't just the automation. It is the fact that people, including people who may not have been in roles where they directly engage with residents or patients, are now don't have jobs. So I think we do have to think about all of these things.
Yeah, well, I'm not totally related with this because, it's the same argument that was, and I wasn't there, but I heard about it when the new car was
Yes.
invented.
Mm-hmm.
And then all the horse guys said, "Whoa, what will be with us? We are going to be fired. It's not good. Let's crash the cars." And then they understand that they can be cab drivers, for
Right.
example.
Right.
So, it's
Yeah.
not black or white
Right.
situation.
I mean, the horses lost their jobs, but maybe that was okay.
Well, yeah, that's for good.
Okay, so I'm going to go back to the slides. There's just a few more. Okay, so that's where our discussion broke out. Okay, so let's look at the limits of AI ethics or responsible AI or some of the other terms that are used in aging society, of that as a way of thinking about social uses of AI in aging societies. AI ethics designed for organizational use and the assessment of clinician-facing tools cannot fully account for AI usefulness to older adults and caregivers in everyday life. This is my big argument. Making the consumer decide which direct-to-consumer tools are worth it for them is insufficient given uncertainty about what constitutes a useful AI tool related to cognition or care, lack of clarity about standards and methods for evaluating these tools that are available to a consumer, a purchaser who's probably a family caregiver, lack of structural supports for users for data privacy, setup, troubleshooting. In the case of the ELEQ pilot, there was being piloted through the Department of Aging, so there was somewhere to call. You didn't have to call like a phone number. And adding to caregiver burdens if the tool is not useful or it relies on a caregiver to manage. My colleague Nicole Werner at Vanderbilt, who's a design engineer, did a project with older adults where they rated mobile apps that were ostensibly designed for care partners of people with dementia. And they said that most of these by users, potential users, were rated as terrible, just not useful. These were things that were up on the Apple shop that were just there as, consumer marketplace. And these were things that clearly had not been developed with people who were at the actual users. And this is one thing that she talks about, that you can't just wait for the tool to be designed and then hope you're going to fix the tool if it doesn't work. You have to enter the process at an earlier stage. So this is something that I'm really interested in as a research question. What are the upstream ethics in some AI labs? Some labs have developed working principles and approaches for designing AI tools integrated into everyday environments that can improve the lives of older adults and of caregivers by supporting social connection, safety, and agency, reducing caregiver burden, and potentially slowing down cognitive or physiological decline. Interest in principles and approaches for what's often called humanistic or integrated AI. These are the terms that are used by the designers, by the way, that support older adults and caregivers, aligns with new normative work on the moral significance of the caregiving dyad. Jason Karlowich, who I mentioned earlier, is also involved in that work, saying we have to remember that in the context of later life, we are often thinking about two people. And we have to think about, we should never be doing something that creates more burdens for the caregivers. And when I talk to AI designers, they'll say, one of my metrics with my trainees in my lab is, did this make a caregiver's life easier? Is it just a toy, or is it making a caregiver's life easier? So in Jason Carlos's story about Peter, Peter was running around being the tech support for his mother, turning her TV on and off remotely through his phone or something like that. It wasn't actually making his life easier, and it wasn't increasing his mother's social experiences. So I know about this upstream work from hanging out with designers. They are forging their own way on this. And I think we need to study this more. The team I would love to talk to would be at Intuition Robotics, the LQ team. I think they probably are thinking in these ways. But this is what I have learned from some research that I'm doing with Nicole Werner and others, and with Amy Huang, who's also mentioned, on principles and approaches that are coming out of the labs and the development process themselves. Co-design with intended users in all stages of design, piloting, and evaluation. If it's for caregivers, you involve caregivers. If it's for older adults, you involve older adults. Openness to co-design solutions other than AI. You might do a workshop with caregivers and find out that what they need, what they call a problem, does not right. AI is not the best solution. It's something else that they need. Maybe what they need is a human case manager or something like that. Maybe that what they need is for a service to cost less. Humanistic, whole person and social environmental perspective, that the idea that the AI should work in your life, not just try to engage you and take you away from other aspects of your life that you may value. Usefulness as a key principle and metric. I love that idea. That is it useful? Not just is it beneficial, but does this serve a practical purpose for the person that they can see? Recognition that engagement alone is a weak proxy for therapeutic benefit. As was mentioned during the discussion, these devices are designed to be engaging, but we do not yet know, we do not have long-term data on whether that means the person is less depressed or feels less stressed. We don't know. And recognition that hard metrics that are often beloved in health policies, such as improved function or reduced healthcare costs, may be misaligned with the reality of progressive conditions. Dementia is progressive. Many other conditions are progressive. So the idea that magically you're going to stabilize these conditions via an AI or any other tool is just something that we have to say, that's just not the right metric. This is a perennial problem in aging research. The idea that you should prove that older people deserve to have good lives. It's so annoying, and I'm sure many of you are familiar with it. But I mentioned here, I just have a couple of screenshots, creating humanistic AI age tech to support dynamic care ecosystems. This is led by colleagues in Canada, led by a very dynamic postdoc, Amy Huang. It was published in the Gerontologist last year. Doing AI differently comes out of the Turing Institute in the UK and is basically saying, let's get humanists and social scientists and psychologists and designers together regularly to work on these problems. And Nicole Werner's work, this was part of the A2 collective, the AI and Age collective in the United States, co-designing age tech for commercialization and impact. In other words, saying you can do co-design, you can have this very usefulness-oriented approach, very humanistic, but also and sell it. It's not something that's going to be impossible and it's just some pie in the sky, research approach. So what are the barriers to wider adoption of this idea that we could infuse normative principles and approaches into design processes? And part of it is because of the influence of when we think about Silicon Valley and just pushing things to market. Industry norms push teams to design, develop, and launch tools swiftly. Co-design is going to take more time because you are going to involve users from the beginning. And AI designers are committed to co-design often rely on research funding. Although, again, I would be very interested to talk to somewhere like Intuition Robotics and say, how does your process work? How do your investors take your approach in developing LEQ? Private sector age tech far outpaces academic labs. So early career AI designers have financial incentives to align their careers in ways that appeal to industry. When you talk to mentors in labs, they'll say, I do have to talk with people about it when they're facing, well, what would an uncertain academic career be like versus signing on with industry? You'd make more money, you know. Collaboration with ethicists and other humanities scholars is challenging across differences of training. So it isn't just you just drop an ethicist or a philosopher in a lab and it's all going to work out well. We don't even know each other. The bioethicists on an academic campus tend to be in the faculty of medicine, not in the faculty of engineering. It's hard to find these hangout opportunities. So what would be better? So my big project is developing a bioethics of AI that is for people in aging societies, for older adults and for caregivers. So one of the things I think we need is to connect upstream and downstream better when we're doing ethics. We need to learn from upstream principles and approaches and encourage their use in academic and industry labs with attention to tool evaluation, not just the design process. We need to create early and frequent opportunities for ethicists, humanities scholars, behavioral and social scientists, and AI designers broadly to explore aging and caregiving as human experiences that could potentially be supported by AI tools integrated into people's lives, not as a problem to be solved. Recognize that this is not easy, but we need to figure out how to do it. On another project that I'm hoping to develop, I'm working with someone in an undergraduate faculty to say, how could we create ways for the philosophers, the gerontologists in the School of Social Work, and the designers in the engineering faculty to actually collaborate on student level projects and understand how they approach problems. And my final thought is we need to focus on human flourishing. We need to avoid, in the high level discussions, in the think pieces, avoid framing problems of humans and AI as problems of AI personhood or moral standing. You can read this every day. Focus on human flourishing. What makes a good life at every stage of life? No matter how real or conscious an AI tool seems to be, we should not grant it moral standing ahead of doing so for fellow humans. We have a lot of work to do with each other. Humans routinely fail to respect the dignity and experience of fellow humans, including people who do care work. We must keep that ethical problem in view and not make it worse when we're thinking about relations between humans and AI. And we need to practice thinking ahead, as we've done in our discussion. What will human life be like when embodied social robots are capable of providing care, while attending to real-world concerns for older adults and for caregivers right now, where the technology is right now? My sources, my slides can be shared, of course. I have the LEQ literature, Charles Binkley's work, some other work on humanistic and integrated approaches, Jason Karlowicz's column. And this is also our most recent report from Bioethics for Aging Societies, which is about cultural narratives and dementia. You can get the full text via the QR code or via our publisher. It's all free. I did a podcast recently with JAMA on this report and its usefulness to clinicians that might be of interest. One of our essays by a philosopher of technology, Mercer Gary, is on technology in the care of older adults. And please keep in touch. Okay, so we've got a few more minutes. So if there's any final thoughts or questions, and please feel free to follow up with me by email if you'd like.
Oren, we cannot hear you first.
Yeah, sorry. So thank you, everyone. Thank you, Nancy. That was, I believe, phenomenal, if that's a good word to use. And I want to point out that, sometimes people tend to think about philosophers and bioethicists as people who present interesting concepts, but that are not always connected enough to daily issues in a way, at least not in a way that sees the daily problems, right? And I think the way you presented, both from, let's say, from looking from high above and then going into the details, that was really important for this specific example that I think is relevant to so many. And I wonder about, I mean, the workaround that you mentioned when we began, because you used this several times, and I was thinking about another term that a lot of us are talking about. We call it shadow AI or something like that. Basically meaning, well, you don't have to embed this in the system. People just use it because it's available. For instance, is this a workaround? Is this a workaround until the system adopts these tools? So I'm just wondering if you have some additional thoughts on this concept of workaround in terms of AI in the field of
Yeah.
aging.
Well, yeah, it's kind of helpful when you've written a book about something because the co-founder of the Hastings Center said you write a book to find out what you think, and it's true. I just sort of had to think about what is this phenomenon that I'm observing among clinicians I hang out with because I've written a book about medical error, and then you realize workarounds are much more common than errors, but they can lead to errors if you just say, oh well, you create a new normal and you realize it's not really safe anymore. But they also are they're the rough draft of anything innovative because you have to change something in order to innovate it. But they tend to operate at this secret level. So I analyze these four different kinds of workarounds, and definitely just and a workaround can be an idea. Sherry Turkle is a sociologist of technology at MIT, talks about, tools to think with and ideas to objects to think with. And it's like so you've got this idea of saying, well, you're trying to create a person. You're trying to create and I did a lot of work in Singapore, which is an aging society that's very aware of itself as an aging society. And there's a lot of reliance on foreign domestic workers who come from other countries in the region. And I remember sitting in a workshop with a young doctor, and he was like trying to get across to the New Yorker, about foreign domestic workers. And he said, "We're trying to create a family member fast." And I just said, and her name would be Cinderella, right? And he laughed, it was like, yeah, yeah, she does do all the work, yes. So it reminds me of that, like ultimately, beyond the idea of engagement and this and that and this, it's like you're trying to create what a person does for another person, and aspects that can be kind of tedious, as Stephen said. It's like the same conversation, over and over and over again can be like, oh, here we are again. And so there may be some things, but we have to, those are also aspects of, if even if a person doesn't have dementia, you've suffered so many social losses when you get to a certain age. The person who you would normally talk to on the phone isn't there anymore. I went to the funeral last week for my mother's oldest friend. They'd been friends since they were 3, and that's gone. She's a memory now. And so we can't replace what people have lost. Um, but people continue to have social needs right until the end of their lives. So how are we making sure that we don't just jump to the idea that AI is the solution for the tedium of hanging out with old people? We don't want to do that.
I think what you represented in the way you've presented your thoughts is kind of a systemic approach in a way, because it doesn't only look at the old person, but at other people that surrounds them. And Amir, for instance, is active in the Caregivers Israel, right? He's chair or president or something like that. And it's a big issue, right? The burden of care. It's a bad word, but it's a true reality, right? And I think that what you're offering here is for us to keep maybe looking at this wider picture, and just to maybe to close that our initiative at the university, we are working on getting together people from the engineering and from philosophy and law and so on. And now we're also kind of connected with one of the hospitals, several of the hospitals, to think together, because really it's important not to look at just one aspect of the equation or one player and so on. So perhaps we could further explore some of the things you mentioned here, potentially in terms of project or research that might be
That would be
something of
great.
interest.
That as an ethicist, I always endeavor to be practical. So that would be very interesting to see how this works and how people across different disciplines, very different training, different ways of looking at challenges, actually communicate with each other. It's so much of this is in that. When I talk with people who are in design labs, they'll say, you know, the way you talk, the way you raise these questions is different from how we're told ethics should talk. Well, it's safety and transparency. It's these
Yeah.
marks, And it's like, yeah, well, you can get that somewhere else. You can get that from the IRB, But having the conversation about the goals, and where this fits within the idea of flourishing in later life, that's what I'm interested in.
Thank you very much. Amir, do you want to say something for closing our session here?
Yeah. Yes. First of all, a lot, Nancy, and I think that today was like a really interesting discussion among our community members, which was really, I think that when the discussion is really dynamic and people are asking the questions and bringing their perspective is really helpful. So for me, at least, it was like really interesting. And yeah, I'm looking forward for thinking about possible collaboration, and we will collaborate soon with the Hastings Centers, as already mentioned before. And yeah, thanks a lot. And I think that we're gonna see you in our next webinar.
Yeah, so
Wonderful.
we'll get the
Okay.
details out. And thank you everyone for joining
Thank
us.
you.
Okay.
Thank you.
Thanks,
Thank you,
everyone.
Nancy.
Great discussion. Thank you so
Thank you
much.
so much. Goodbye.